Thank you, Juan David. Thank you, colleagues, and good morning, everybody. Good morning, good afternoon. Welcome to this webinar on integrating health services to accelerate the elimination of communicable diseases in the Americas. Thank you for your time. It's a privilege to have all of you today to share the experiences in the region of the Americas. Before starting with the agenda for this webinar, please note that we have simultaneous interpretation services in English, Spanish, Portuguese, and French. And also we encourage all of our participants to use the Q&A option to ask your questions that we hope to be able to at least answer some of them after the panel discussion that we are going to have. Integrated health services, delivery, linking, prevention, diagnosis, treatment, and follow-up access health services networks are essential to expanding access to communities that are affected by communicable diseases and are also important to protect the elimination gains, particularly among populations living in vulnerable conditions. This webinar, organized by the Pan American Health Organization and the Elimination Initiative, it is focused today on practical country experiences and lessons learned in integrating health services to accelerate the elimination of communicable diseases. So we hope that you enjoy this session today and learn about what some of the countries in the region of the Americas are doing. Without further delay, it's my pleasure to introduce Dr. Sylvain Aldiguieri. He is the Director of the Department of Prevention, Control, and Elimination of Communicable Diseases at the Pan American Health Organization, who is going to give us the opening remarks for this. And apologies for not having introduced myself. And Marta Saboya, the Regional Senior Advisor on the Disease Elimination Initiative at the Pan American Health Organization. So Sylvain, welcome to this webinar, and the floor is yours.
Thank you, Dr. Saboya. I'm very honored to have been invited to participate in this session, and I will try to share with you some considerations and based on the experience of the organizations, but most importantly, of the experience of the countries. And also, in addition, I'd like to recognize the participation of countries for sharing their experience, starting with Barbados, but also El Salvador and Panama. Let me switch to Spanish now in order to ensure a balance in terms of languages. And distinguidos colegas.
Dear colleagues, once again, it's a pleasure joining this session on behalf of representatives of ministers of health, partners from the Americas, and probably guests from other regions around the world. This webinar addresses one of the most important positions in order to achieve the elimination of diseases in the Americas. This is the number one action line of the Elimination Initiative. The ability of health systems to integrate services around the needs of the people and communities. So PAHO, well, we feel very proud of supporting the countries in advancing this pillar, the most transformative pillar, the elimination of over 30 communicable diseases by 2030. And once again, it's the integration of healthcare services to better react to affected populations by communicable diseases, particularly those living in vulnerability situations. So during the last few years, by the last few years, I mean 20, 25 years, the Americas have shown the elimination of diseases is something possible. It's really possible. Our region has managed remarkable progresses, but persistent diseases focus on communities facing barriers such as geographic isolation, poverty, social inclusion, limited access to quality healthcare services. But in terms of isolation, sometimes we have cultural isolation, meaning indigenous communities, Afro-descendant minority groups. The Elimination Initiative recognizes the elimination, it's not possible in isolated way, disease by disease. We need to focus on people integrated in one single healthcare primary care, supported by networks of service delivery. And let me add the importance of the role of the scientists, of the volunteers in very remote areas, which may be isolated within urban areas. So elimination efforts will also strengthen healthcare systems and promote universal access. Let me recognize the leadership of countries, which is leading into practical models. Their experiences are critical. For instance, certification of elimination of malaria in Suriname in 2025, in July 2025. That's a result of 25 years of investment in integrated networks with a focus on indigenous people and primary care. So we'll be listening to how El Salvador has been using the trachoma elimination strategies to provide services to rural remote communities. As another Barbados, which is driving mother-to-child effort to eliminate vertical transmission of HIV, syphilis, Hep B, and the example of Panama, which is addressing transmissible communicable diseases in populations in prison adapted to a highly vulnerable environment. Those examples show integration is not one single model, which needs to be adapted to the context and led with the national and subnational leadership. The elimination is not measured by epidemiological goals alone. Also, we need to achieve these results by reducing inequities, eliminating barriers, and guaranteeing access to healthcare services. So we invite everyone to actively participate today. Let's discuss how these lessons may strengthen efforts in your own context, but also in a multi-country approach. It doesn't mean the country right across the border or right across the river, but right across the continent. I'd like to thank our speakers, and once again, colleagues from El Salvador, Panama, and Barbados, representing their countries, and all those that have made this dialogue possible, which will inspire us to in our efforts for eliminations. Really, once again, thank you for joining today. And once again, Martha, back to you as coordinator of this webinar. And now I'd like to greet Dr. Bascolo, who will be presenting next, I believe. Thank you, Martha. Thank you, Ernesto. Thank you, Dr. Aldigeri, for your opening remarks of this important webinar and for setting the pace of what this will be today.
Now it is my pleasure to introduce Dr. Ernesto Bascolo. He is the Unit Chief of Primary Health Care and Integrated Service Delivery at the Pan American Health Organization. And because the topic today is how integrated health services can accelerate the elimination of communicable diseases, for us, the role of those working in those areas is critical if we are talking about acceleration in the region of America. So Ernesto is going to give us an overview of how integrated health service delivery networks accelerate progress towards disease elimination goals. Ernesto, thank you very much for your participation, and the floor is yours.
Thank you, Martha. Good morning, everyone. It's an honor being here with you today. The elimination of diseases agenda, as you have said, is not just a goal focused on individual diseases. It's a challenge comprising that makes us to build agendas to strengthen the healthcare systems. Following your introduction and your question, let me focus today on how the new integrated network of healthcare systems by PAHO is not just a theoretical review, but a roadmap, quite operational, in order to speed up these, to accelerate these elimination. In other words, how to use what we call the integrated network as an operational tool for these acceleration process. For these, let me share with you some innovations in this framework. Let me try to interpret how we can build operational, say, avenues in this acceleration process. The first innovation in this document is the people, community, family center model. Why? Because this is critical for elimination. The disease you would like to eliminate, such as trachoma, malaria, vertical transmission of HIV, that plays in the void. People have challenging lives within communities settled in defined territories with given characteristics, both cultural, economic, social, political conditions. And when going from disease care approach to a continuity of care, we're guaranteeing that the system will not lose, will not miss the patient. Besides, this co-responsibility between users and the community, I mean, users, community, and the healthcare teams, this link between users, community, and healthcare centers will guarantee not only adherence to treatments as a critical factor in order to interrupt transmission of any pathology, but also this link between user communities and the service is critical for building the trust with the population and the healthcare centers or services. The second innovation in this integrated network is the redefinition of the governance at 3 levels. At a macro level, including definition of statewide policies. We assume that when we talk about governance at that level, we mean the political commitment from healthcare authorities, how this elimination is top priority, even as part of the healthcare policy. There is a second level dealing with meso management, which is in a critical spot of coordination of networks of healthcare system with all resources, with all the organizations. And last but not least, a governance focus on management, the micromanagement, and the rendering of delivery of services within the territories by adapting to epidemiological, cultural realities of the services within these network. So here, of course, the concept of the territorialization is critical. We cannot eliminate a disease with one single solution without considering diversity in the territories, but how services operate in the area, how communities live, are organized, even considering, as I will be explaining later, the state, how the state is organized within the territories. In this case, integrated networks allow us to mobilize all stakeholders not only, as I said before, those within healthcare and services, but also from other sectors, what we might call intersectoral stakeholders with a critical influence on the territory. Like we will be discussing in cases, the elimination takes place when healthcare sector, it's organized with the housing, justice, among other many sectors. There is no integration without information. And this document of integrated networks position the digital transformation as the basic mesh for the whole network, not only telemedicine, AI, electronic record. The information component is critical. Really, it's like the backbone of the whole system. And since in order to eliminate a disease, we need data, real-time data. Interoperability allows for a result from a laboratory in a given rural site can trigger epidemiological surveillance reaction throughout the whole network. Last but not least, let me emphasize yet another important component of this network approach, which is change management. Not only the importance of what to do, but how we make a change process possible by changing, transforming not only services, but also stakeholders, how we change, how we transform the model, the ability to react, to respond to the health needs of the population by accelerating the elimination of these diseases in the most effective manner possible, in the most efficient way, with an impact on equity. Now, the disruptive portion of this update of the integrated network, which is clearly departing from a more hierarchical, vertical, normative model, only setting what it needs to be done as to how the healthcare services should be organized. And the component you refer to, for me, it's a critical. Not only the network has to be flexible, dynamic, but also needs to adapt to the different territories, like I said before. In this conception of network, services from different challenge levels will allow for jail services in Panama or rural clinics in El Salvador are not in isolation. There are nodes of a system comprising them. Now, let me make an interpretation of the integration approach of these document by Rees, and I will do this bearing in mind the axis of integration in the document. These axes are the driving forces changing a fragmented system into a much holistic approach, but looking for accelerating the elimination strategy. First and foremost, the first two axes, integration of healthcare and the integration of the programs. Elimination programs historically worked aiming at it in an isolated manner. HIV budget, a different one for hepatitis, for malaria. The innovation is that these programs not only should be streamlined, but be part of the network. When we integrate, for instance, the elimination for mother to child strategies, such as in Barbados, in the prenatal routine controls, we're not longer expecting patients attend going to the HIV service. The network will make use of each one of the clinical network in order to screen, to eliminate the lost opportunities. This is how we see it. Which are the number one obstacle to accelerate this elimination process. The third axis is integration of individual care with public health. And the traditional model, healthcare teams were responsible for care, while epidemiology was related to surveillance, health surveillance, with the little coordination between these two worlds. Networks aim at breaking away with this barrier. We need to articulate a public health perspective where the different centers are known. So without a doctor in El Salvador, if a doctor in El Salvador identifies a trachoma, the network not only will focus on the network, but it will trigger a territorial reaction and response. Elimination needs the speed of response given to clinical epidemiological integration in an integrated concept. The intersectoral and territorial integration, as I said before, it's critical. We know poverty, crowding, and lack of drinking water are key for infectious diseases. These is an execute. This is the ex. These will implement different actors. Justice, which is critical for Panama, and jails, education, housing. The network not only is dealing with diseases, but also is changing the environment leading to disease. We cannot eliminate tuberculosis in a jail or in a rural community if these network doesn't have sound bridges with non-health sectors. This is my foul. If we need to accelerate the elimination of communicable diseases, that we need a network adapted to different contexts, which needs to be dynamic, cohesive, aiming at accelerating these multiple integration axes. Thank you, Martha.
Thank you, Ernesto, for putting on the table all this, which is an accelerator. With this opening, we will start with the experiences of the countries, and we will be presenting 3 experiences. As Ernesto said, we will start with El Salvador, the integration of health services through the strategy of elimination of trachoma. For that, I would like to welcome Alexandra Portillo from the Office of Prevention of Tropical Diseases in El Salvador. Dr. Portillo, welcome. I hope you see us. The camera is not working. Okay. Good morning. My name is Alexandra Portillo Monterrosa. I am a technical collaborator in the Office of Tropical Disease in El Salvador. We would like to welcome you all to this webinar. We will present part of our experience in integrated systems of health through the strategy of elimination of trachoma. Thank you very much for the presentation. Salvador, for those that don't know us, we are a very small country, warm, and we have a population of around 6,551,000 inhabitants. This for the census of 2024. Salvador is located in Central America, north with Honduras, Pacific Ocean, and Guatemala. It has a territorial extension of 20,040 square kilometers, and we are organized in departments, municipalities, and 262 districts. This has had a change. 3 years ago, we have been changing the geographic delimitation, and we are keeping the same geographic extension. Thank you. Population, we are more women and men, 47.5%. We have an estimate population in the area we work for the Trachoma survey, 140,797 inhabitants. Now, starting in 2023, El Salvador began with this was part of this regional initiative as part of the public health. We wanted to see if trachoma existed in our country. We prioritized our country. We made a selection in the evaluation of trachoma, a technical table. We were selected by the Minister of Health, and they decided who was going to be in this table. Different areas took this responsibility and the opportunity to start searching for trachoma. This table allowed us to define different areas in community levels to see which were going to be our variables that were going to allow us to search in different areas with different vulnerabilities that could be within our search. This is where we have our integrated system of health. And we sat with different stakeholders so as to look for those key areas in search of that disease. Please let me know if I'm going too fast. What was the methodology that we used so as to prioritize at a country level and select those areas that could be considered vulnerable? Search for risk factors. I will not go into deep in the disease, but the features that we were looking for. Poverty index, socioeconomic conditions, the number of inhabitants per household, rural areas, or if we have a high density, or the number of inhabitants, as we said, in per household, the percentage of population illiterate, and the percentage of population without access to drinking water. This is a key aspect. So that could lead to different diseases, and which were the other diseases that we were also considering. Population, the number of people, and also analyze contamination and also the problems of the different diseases. The number of houses with the floors that are dirt floors, and we started putting a percentage. We gave certain percentages, and we focused on those areas that we were going to work with the checks for trachoma. We had 250,000 inhabitants, and that was more or less the population. And we saw the areas where trachoma was a problem of public health. All these variables gave us the opportunity so as to start these surveys. Areas of intervention that were selected, 5 in total, 5 departments: Aguachapán, Chalatenango, Usulután, San Miguel, and Morazán. We had a division, a change in terms of the district division in our country. That's why I started with the geography of the country. And we have geographic areas that are very difficult to access. Many areas had to be accessed by foot. We could not drive to those areas. The area we worked the most was in the east side of our country, Usulután, San Miguel, and Morazán. We see them to the right in the map. And Chalatenango and Huachapan in the west. So we had some areas, municipalities, specific municipalities, Huaymango, San Pedro Puxla, Tacuba, San Francisco, Morazán, Alegría, Jucarán, Carolina, San Antonio del Mosco, Capoeira, Chilanga, Guatejir Agua, and San Simón. These are the areas we were going to need to do the search for that disease. And we selected the areas where they had vulnerabilities. So we wanted to identify those systems. How are we going to integrate with other health systems? We did effective communication at all levels. We have our flow chart, the Ministry of Health, primary level, secondary and tertiary level. And we divided the health units and the hospitals. To make communication effective in the different health units was our main focus, because this is where we were going to work with the population. And they were at the primary level. We coordinated with these levels, and we sat in the technical table. And the person that was in charge of these interventions was our health promoter. As they know, or they identified the children or the population they work with. And our health promoter was the key person to start with these surveys. And that is how we had some interventions, and not only the surveys, but integral assistance as visual health over people over 60 years of age, environmental health, so as to we can use a wash fit tool. We worked with National Lab of Public Health. They measure the water quality, and also worked in dengue. As you know, our country is a disease that is widespread in our territory. So we had to work and take advantage of that and start with the activities of search. We also did a coverage of vaccination. We have also calculated the number of people and children that have not been vaccinated. So we took advantage of this opportunity, not only for one type of activity, but also vaccination. This allowed us to do to move forward in our activities, not only focusing in one activity, and that is where our system integrated with other areas, vaccination, health, and also eye health. That allowed all the stakeholders to identify ourselves and integrate ourselves. You have 2 minutes. As I was saying, the results, as we said, was the eye check, the wash fit, and water. We were able to achieve those activities, a promotion of health in all these areas. And with the work we had in other areas, our next steps were to complete these activities and move forward in the plan, and hepatitis, endometriosis, and others, and optimize the human resource. And we expect to get to the elimination of trachoma in El Salvador. Thank you. Thank you very much. I hope we passed the message, and I hope this has reached all the units. And this is what we did in terms of our survey in El Salvador. So sorry, I went very fast at the end. Thank you very much. Now that we will go to the panel, maybe we can talk further on the lessons learned, because it is a platform where we are rendering a service, not only for one disease, but El Salvador was able to take advantage of this and enable access to integrated services using this same logistic. Thank you, Dr. Portillo, and we will ask you for further information later. Thank you very much for your
Going to switch into English. And I would like to welcome Dr. Elizabeth Mandeville. She is the Medical Officer of Health at the Ministry of Health and Wellness of Barbados. Dr. Mandeville is going to share with us the experience in Barbados integrating services to eliminate mother-to-child transmission of HIV, syphilis, and hepatitis B. So Dr. Mandeville, welcome. Thank you very much for the opportunity to share the experience and lessons learned in Barbados. The floor is yours.
Hi, good morning, everyone, and thank you for inviting me to this initiative. So today I'm going to be presenting on integrated services to eliminate the mother-to-child transmission of HIV, syphilis, and hepatitis B, and how this service integration at the point of care shapes our national EMTCT response. So Barbados is known as the most easterly island in the Caribbean. It has a land area of 439 kilometers squared, and our population is 264,748 persons. We also have 11 parishes, which are our geographical divisions, and our public health infrastructure consists of one main hospital, 9 polyclinics, which are primary care centers, and 3 satellite outpatient clinics. There's also 1 specialized HIV care and treatment center. And you will see on the map where the healthcare centers are located. So a regional milestone and where Barbados stands. So 11 Caribbean countries and territories have already received the World Health Organization validation for the EMTCT of HIV and syphilis, and this is a major regional public health achievement. Barbados, we had a PAHO pre-assessment completed in October 2025, and a formal application was submitted with HIV validation anticipated as the first milestone for Barbados. So why are we sharing this approach? Although Barbados has not yet received the validation, our health system has been quietly delivering integrated services for the EMTCT for many years. And the way that integration is organized and where it lives in the system may offer a useful complement to existing regional models. So, our health system overview. Our primary healthcare system is a universal government-funded system complemented by private providers. It has free access to essential services for all residents, including migrants. And there's a focus on preventive care, maternal and child health, and chronic disease management. Emerging challenges, however, are the aging population in Barbados and the rising chronic diseases. Our secondary and tertiary care comprise of the centralized hospital, which is the Queen Elizabeth Hospital, and that has 600 beds. We also provide surgical, medical, maternal, emergency, and diagnostic services. And the majority of the births actually occur at the Queen Elizabeth Hospital, where they have approximately over 90% of births every year on island. The other births are obviously done in the private sector, and these are delivered by ONG specialists, but we also have private sector delivered by general practitioners and private medical centers. There's one private hospital and one birthing center in Barbados. For our pharmaceutical services, the public system is managed by the Barbados Drug Service, and this provides free or subsidized medications via the national formulary. It also supports chronic disease management and ensures that drugs are available for patients. The HIV and STI services. So HIV testing is integrated across all healthcare facilities. The HIV care and treatment via the Lady Mead Reference Unit, which is a specialized care center, has comprehensive services as well, including testing, treatment, counseling, and prevention. There's also PrEP that was introduced in 2018, and this is available at multiple sites on island. There are also shared care models between public and private providers and civil society organizations. And for the National Wellbeing and HIV Commission, this is an organization that leads the multi-sectoral HIV response and well-being initiatives. They also focus on vulnerable populations and reducing stigma, and they work with the Ministry of Health and Wellness on policy, coordination, and evaluation. So in Barbados, the polyclinic is the integration point. This is where the maternal, child health, sexually transmitted infections, immunization, and postnatal services are co-located and co-delivered. So the polyclinic, in a nutshell, is the integrated point of care, and it has antenatal care, immunization, STI testing, surveillance and follow-up, postnatal and child health, family planning, and counseling. So there's one team, one record, one location. And this integration is operational and not just structural. So the shared operational leadership for the antenatal care. At the center of this diagram, you will see that we have the mother and the baby. And this is where the primary care team at the polyclinics, they will deliver these services. But we also have relationships with the senior medical officers of health for the HIV, which currently leads the EMTCT response, the maternal and child health, which deals with the maternal, newborn, and infant care, the senior medical officer health for the NCDs, which help with the maternal mental health support, and also the senior medical officer health for surveillance, which helps with the communicable disease surveillance. Critical to this particular shared antenatal care is the nursing aspect. So we do have the chief nursing officer, the chief public health nurse, and they're the daily coordination of the nursing workforce. We also have the polyclinic, senior health sister, and health sister, and those are the ones that are at the front line for the antenatal clinic, and they deal with the patients on a day-to-day basis. They also assist with follow-up. And also the polyclinic doctors, they help with the clinical management at the primary care facility. So the national level leadership is advisory, and decisions about each mother and baby happen at the polyclinic by the team. So the EMTCT pathway, this is how the flow goes here in Barbados. So when patients come for their first antenatal care visit, they have their consultation and counseling. We also take that opportunity to do something called booking bloods, where we take all the relevant blood laboratory specimens that the antenatal patient would need for their entire care, including the routine triple testing of HIV, syphilis, and hepatitis B virus. The mother then would return to the polyclinic for their results. And if the results are negative, then they will continue the antenatal care at the polyclinic. If results are positive, then this means that they would need to either have immediate treatment or referral to a specialist if necessary. And once the antenatal mothers, both positive and also those who are negative, when they get to a certain point, all of them are delivered at a tertiary care facility. Then we have the postnatal follow-up, where the mother and the infant, they would return to the polyclinic, and we continue to do surveillance and monitoring of the mother and the baby. So you will realize that we have one team, which is the primary care team for the antenatal, and we also have STI testing, and we coordinate this face-to-face daily. There's one record, and we usually use the National Patient Identifier, which links all services, and it's one location. So the mother and baby, they return to the same polyclinic to continue care as well. So the lessons learned here in Barbados, we have a strong primary healthcare system, which is critical. Early integration of HIV testing drives our success. The importance of data quality and surveillance also is essential for our management and care here in Barbados. And we do have public-private partnerships which enhance the service delivery. So on reflection, there is one goal that we have, but many pathways. And the service integration is what matters. This is where it lives in the health system, and it can vary by country context. Integration is where it counts. So in Barbados, integration is operational at the polyclinic, where the antenatal care, the sexually transmitted infection testing, immunization, and postnatal care coverage for the same patient occur. The leadership is shared. So since the delivery is integrated locally and the national team can come from any relevant discipline, currently, the senior medical officer health responsible for the HIV and STI services is responsible for the EMTCT, and the system still works effectively. And even though PAHO recommendation was to anchor the EMTCT in the maternal and child health, it is an excellent model. But here in Barbados, we have country pathways to the same goal, and we thought that it is worth recognizing this as well. So thank you very much.
Thank you very much, Dr. Mendeville, for such a strong message about how integration is happening at the primary care. I really want to highlight that, and how the antenatal care services are anchored at the center of the population, especially babies, mothers, and you in Barbados are leveraging that platform to deliver multiple integrated health services, vaccination, testing, treatment, under the umbrella of the antenatal care. So thank you very much, Dr. Mendeville. I'm sure that the discussion after the presentation is going to be very rich. Thank you, Dr. Mendeville.
Thank you.
Excellent. So with that, I'm going to switch into Spanish.
To welcome our colleague from Panama, Dr. Miguel Teo. He is head of jail health from the Public Health Bureau in Panama. Dr. Teo will share with us the integrated approach for communicable diseases in jail population. As you see, we've had two different contexts. El Salvador, how to reach scattered rural population. In Barbados, they're using the platform of a prenatal in order to accelerate the elimination. And now populations in jail affected by these communicable diseases. Dr. Chill, once again, thank you. And thank you for the opportunity to share the Panamanian experience. Good morning, everyone. Can you hear me okay? Great. Okay, let me thank first for the opportunity to share with our colleagues this piece of work we've done in jails and prisons at the national level here in Panama. Without further ado, then, let me begin my presentation. As you said, I'm head of a prison health section in the Ministry of Health in Panama. As part of the Public Health Care Bureau. In Panama, we have around 19 prisons or jails where we have to monitor 19 throughout the country. But today we will focus on the most important one, which is the biggest, the largest, called Complejo La Joya. That's why I mentioned it's 19 prisons. It's not one. The total population is around 24,000 inmates. But La Joya accounts for 15,500 inmates. The number of inmates will always change, growing or decreasing, because every week we release and we have new inmates. So La Joya comprises three different jails. One is La Joya, Joyita, and Nueva Joya. So this complex is the only one with a full hospital for inmates. That means inmates have general practitioners, have dentists, emergency, pharmacy, laboratory, radiology. Now we have other emergency hospitals, and for HIV patients, as well as tuberculosis patients, which is the matter of the discussion today. So, since this is the only hospital as such within the largest jail complex in Panama, all our hospitals follow the healthcare rules for inmates. Why? Not only inmates, but as part of that, we comprise infants or underage with legal issues. So these rules are to guide the healthcare for these inmates. Panama, as I said, has an agreement with the Ministry of Government. So the Ministry of Health creates an agreement with the Ministry of Government, with the Ministry of Safety and Security to treat these inmates, to treat these health care need in jails. So each one has, as part of the agreement, will make a contribution to achieve the ultimate goal. Like Ernesto said, this primary care, which is prevention, we try to prevent at least the case of tuberculosis and HIV. We try to guide these inmates by using dissemination, visits, daily care for these inmates. Next. Next, please. Thank you. So this is the HIV table. What do we have in Panama as part of La Jolla complex? We have a cohort of 183 inmates with HIV. This population has grown, not because HIV is replicating or this is disseminated, but we have had the healthcare promotion within the prison system. We have make visits. So we've done screening to detect HIV. So by educating inmates, they are become more aware of the tests. When going through these tests, we find more patients. And as part of the program of the TARV, as an antiretroviral therapy, inmates are become more aware, as I said. And we have had the possibility of disseminating within the gay communities, and we have distributed condoms. Thanks to this education, which has been replicated throughout the prison system with these inmates, we have been able to find and address the problem once and for all. So when these inmates are released, what we do is that they live with us an address, a home address, and we try to contact the healthcare center near the address to let them know that the inmate so-and-so is being released so that this healthcare center can address these. Many times we don't know when they are released, but once we receive the report, then we transfer all that information to the healthcare centers so that they can find them and to follow up with this treatment. Next.
In the case of TB, we have this, which is something that we have been gathering since 2021. In this case of relapse and incidence, it's not that it increased in 2025, but rather now we have more tools for timely detection of TB within the jails. And we have here the jails, and it's the excess of population. If we don't work, if we as government don't work in reducing that excess of population, it will be very difficult to control these type of situations within the jails, because the excess of population is a promoter of the fact of transmission of TB. This takes us to these results. What have we done in Panama to detect these? We have created within our standards of screening, we have pair groups. Pair groups is to train the person in jail, the person in charge of custody and all those that are managing the jail to detect some features that might be suspicious of TB. They don't need to be a doctor, but if they see certain issues, they might suspect of TB with the different symptoms. They send the person to the clinic, and then we do all the testing and determine if that person is TB positive or not. This has been successful for us because we have detected that in a timely manner. The success percentage is almost 100%. I feel very proud. They need to take the medication and they are followed up. Relapse, well, these are patients that have a comorbidity, so therefore it's a bit complicated, and that's why we see relapse. We also have patients that come with TB positive, and they take the treatment in Liberty, but then they come to jail, and it has been on and off. A judge has sent back to jail those that have been freed because they have not followed the treatment. This judge has helped us to make these patients to continue with the treatment. And if they are free, they need to go back to jail so they can continue with the treatment. We have seen some cases of resistance, and that is a key issue because that person is resistant and therefore is a vector, and it will extend the disease in the area where he lives and works. So this patient specifically has had a constant relapse. Our population in jail is controlled, diagnosed, and thanks to the program that we have with the peer groups, it has been positive follow-up. This was the first quarter. We have 38 detections. And this is for you to see how is the jail where we have the isolation area. This is for those patients with TB. This is in La Nueva Joya. And it has a 2-level, 12 cells, 12 in first floor and 14 in the second floor, for 5 individuals. That is a total capacity of 130. In La Joya, we have 110. Right now, TB positive. We lost Dr. Sheo. I think he's not online. Let's wait for him, see if he can reconnect. This was his last slide. Hopefully he will reconnect. Thank you, Dr. Sheo, for sharing the experience in control and elimination of HIV, TB in the population in jail, and coordinated work of the Ministry of Health with other ministries. I'm back. So sorry. So sorry. I got disconnected. So sorry for that. I was finishing. And we can extend it later in the Q&A section. Would like to invite everyone to share the opportunity that we have in the peer-to-peer follow-up. That has been a successful experience in Panama. Thank you, Dr. Shell. Thank you for sharing your experience. I would like to invite back our presenters, panelists, Alexandra Portillo, Dr. Mendeville, Dr. Cheo. We will now ask you about the specific information, about the rich information and experience that you have talked about today. Dr. Portillo, I would like to start with you. Sorry, I had feedback. Okay. Dr. Portillo, please comment us under your perspective, which were the main operational challenges, because you chose very remote areas with a complex socioeconomic situation. What were the main challenges you faced? How did you solve this in this integrated approach in the platform of Trocoma, but also including all those services, additional services? In our first challenges, the Ministry of Health had different programs. We work as in islands. When we had to work, we had each area with their own indicators, with their own targets, with their own guidelines, and we had a period that it was focused only to that program. So when we sat down and we started talking about, well, we do this way, we work this other way, we ask for this, we ask for that, it was focused on each area. How did we achieve that? To solve all these issues? Well, the minister said, let's send a note. We need to sit down. We need to do a technical table. And all those areas we need to work together should be done together. And we should start seeing how are we going to integrate ourselves to work together. And that is how epidemiology in health, ICE health and infectious disease, along with health, all the well-being, etc., we were going to work in all the populations. So unifying those indicators was key for success. And today, we can say that that has definitely helped us. And it has shown that we were able to come together to integrate. And with that same approach, we're going to start working in other projects because it worked very well, having a technical table, a technical team. And you also talked about this technical table. That is, how are we going to work in vertical, in horizontal? Where are we going to cut funds? Where are we going to put funds? So in that technical table, you were able to work together and take advantage of that. And this...
Going to switch into English. Now, this brings me to the point, Dr. Mendeville, that you very well highlighted in these coordinated efforts between different people and programs. So my question now for you is, what were the main challenges that Barbados encountered in meeting and documenting that you probably and likely have achieved the elimination of mother-to-child transmission of HIV, and how Barbados and the Ministry of Health overcome those challenges in the path to that elimination point?
Okay, thank you for your question. So to meet the criteria for the validation, we needed to have at least 3 to 5 years of data. This meant a retrospective process had to be undertaken to review a lot of files. And in Barbados, unfortunately, a lot of the files are paper-based. And we have approximately 2,000 births a year. So you could imagine trying to go through 3 to 5 years of paper-based files. So this was extremely time-consuming, and we also found a lot of gaps in data, both in the public and in the private sector. And also the labs, because as I said, we would have been taking the HIV, the syphilis, and the hepatitis B. Those labs are done at different laboratories, and they also have multiple platforms in order to collect the results. So there was a lot of fragmented electronic systems in different places. There was no single output. And ways that we had to try to overcome some of these challenges is that we had to have multiple meetings with the private sector, with the polyclinic staff, with pediatricians, obstetricians, and also the laboratory as well, to verify that the results were correct, and also that the treatment processes, the guidelines, the referral pathways, all of those things were being done correctly as well. And we also improved the electronic reporting tool that is used in the polyclinics to submit data every month. And we also implemented a similar tool in the private sector, so that the data that's collected on a monthly basis was, better quality as well. And in the long term, we're hoping to have a digital health information system platform across both the public and the private sector.
That's great, Dr. Mendeville. And you highlighted something that is critical, because you mentioned in your presentation that we have several countries that in the region of the Americas have achieved the elimination of mother-to-child transmission of HIV. And sometimes we said, that's probably that easy in a small island. And it's not. You are facing a lot of challenges. You mentioned, for example, how you are coordinating with the private sector. And sometimes that is a difficult task in countries, trying to demonstrate with data that you have achieved the elimination point. It's not that easy. You need to prove with data that you have achieved that, and that you have the capacity to sustain the elimination point. Because actually for elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B, is an elimination as a public health problem. So that means that could be reversible. And in that way, the country has to have the capacity to protect that. So you have identified very well all the areas in which you have experienced challenge. And I really appreciate that you highlighted the topic about fragmented information systems, yes, and the challenges of coordination among the different actors within the health system. So thank you for describing those challenges. So now I'm going to switch into Spanish.
Group that we really need to address comprehensively if we want to provide comprehensive care, but also to contribute to elimination of diseases such as tuberculosis and HIV, which you clearly shown with your data. And then the largest jail or prison in Panama, La Jolla. What are the challenges you face, and how did you manage that effective coordination between ministries, Ministry of Health, and the Ministry of Government, as you mentioned, Dr. Xu? Your microphone is off, Doctor. Can't hear you. Okay. Yeah, challenges were very big. The program has already 18 years. I've been working in this system for 18 years, in this prison system. Challenges were huge, as I said. I mean, sitting around a table, the Ministry of Government, Ministry of Security, and to have an agreement with them. I mean, we achieved the goal, and we created this triparty agreement. To date, we've had renewed the agreement 3 times. As you know, over the years of experience, we can renew, we make changes, and we improve. So, overcrowding is probably one of the most important issues as part of the agreement, because even though we built jails, but we never take into account an isolation area for these inmates. All of a sudden, the one drawing the blueprint, they forget that you have sick inmates. So this isolation area, it's left aside, and we have to attach new areas. At La Jolla, we had an isolation area, as in the last picture we showed. Even though we have a good capacity, but sometimes we are overcrowded, not because our patients from the complex, but they come from other regions in Panama, from other provinces in Panama. They send the inmates suffering tuberculosis so that we could isolate them, because they do not have isolation areas. So that's one reason. And the other reason, when we created these peer groups, which was an interesting challenge, a big challenge actually, making inmates understand, training them, training the guards in their best interest. If a patient in a jail, I mean, they have direct contact with these inmates. Well, guards, if the guard is infected, they will take the disease home. So building this awareness among administrative staff, guards, inmates was a big challenge. But we achieved that. We were successful because, but mainly inmates they always want to learn, and they always want to do. Well, so sometimes they overreact a little bit as usual. But we find these people, we offer treatment on a timely basis. The same is true with the HIV patients. We've built the antiretroviral clinics, which are specific for these type of inmates. That is, there is no positive inmate without treatment, but they will all have their treatment. They will all have a follow-up, markers, uh, viral burden or viral load lab panels, and if they go into AIDS, they are taken to a different hospital with infection specialist for stabilization, and then is sent back to the jail, and then we continue the follow-up. Thank you, Dr. Chu. I believe that the prison population is a critical issue in the whole region. From PAHO, we've been working with every country so as to support an integrated healthcare. Last year, we published the HIV, tuberculosis, and the viral hepatitis and sexual transmitted infections guidelines, including Panama, so as to accelerate that integrated healthcare. Thank you, Dr. Chu, for sharing those challenges. Dr. Portillo, I'd like to go back to you. Based on this experience you've described, where you refer to the work with the local teams and communities, as you said. If you were to give a country a recommendation as to how to effectively engage local people, for them accepting interventions, to give access to intervention, and to provide this provide continuity for this, what recommendation would you give? First, a technical discussion, a technical group, institutional communication, and communication with other stakeholders, such as municipalities, which is critical, working together with other associations. I mean, this is having the community leaders, for us, are key people. People will listen to them rather than the doctors, the health promoter. It's a very important person for the community. So probably the most important thing is to sit and have a dialogue and discuss the interventions for communities in order to have them integrated. Promotion of healthcare, that's very important for communities, how we will be doing it. This facilitates the work of the visual healthcare, vaccination, earthborne minthiasis, which is part of this scenario. First, we need technical discussions, technical groups, so as not to work in isolation, as not to work in the top down or bottom up. Probably this is the best recommendation. Working together, becoming aware as a Ministry of Health people that we are focusing on the population. We'll be working with children. The Ministry of Education, they work with children. We also work with children. So population is the same. So we cannot work in isolation. We have to work as a team. That's my number one recommendation for all countries. I believe everyone will agree with me. If we expect the authorities to tell us what to do, I mean, the population is the same again. Thank you. I mean, that's the best recommendation I can offer. I mean, Dr. Portillo, it's based on your experience, right? And it depends on the context. I mean, what is the context, such as in El Salvador, or in other Latin American countries? I mean, that's a reality that you're sharing with us. So this is, we profit better if we work together. The same healthcare teams at a local level, the same populations which are affected, not only with the communicable disease, we have chronic mental health, violence. I mean, this is what you're showing is that there is a growing need of saying, okay, here on top, we have the specialists, but down there, the context requires these approach you are referring to. And if the case of El Salvador, this technical team becomes this synergy and catalytic efforts. I mean, if that's number one step, okay. Dr. Mendeville said the same thing, and Dr. Chu, where do we sit to coordinate? So thank you for sharing that recommendation.
I'm going to switch into English, Dr. Mendeville.
Yes, please.
So Barbados has been very successful in this process of EMTCT plus. What would be the three key practical recommendations that you offer to other countries to leverage the EMTCT plus platform to strengthen integrated health services for populations that are targeted for elimination of multiple diseases?
Okay. Once again, thank you for this question. So in an ideal world, you would want to have one national electronic health record and, one platform where you could input all the data, one platform where you could see all the lab results, and also where you can see if the treatment protocols are being implemented as well. That would be, I guess, one of the key practical recommendations. The second one I would say is to have a continuous private part private-public collaboration, because we realized that the private sector they were very integral in this process. And as you said before, sometimes you could have some challenges with them. So we need to have a continuous rapport going on with on the guidelines, on the testing, on the treatment, and the referral pathways. And also if there are any new guidelines or testing that are occurring, we also need to make them aware of that as well. So having constant meetings and continuous updates with the private sector is integral. And last but not least, I would say that you need to strengthen surveillance generally, not just to the HIV, the syphilis, and the hepatitis B, but all diseases, by strengthening the national health information system that tracks the perinatal outcomes beyond the HIV, syphilis, and hepatitis B. Having a sustained EMTCT requires reaching to also the most vulnerable patients as well. So you need to have a differentiated care model for key populations, for partners with civil society organizations, and to have an integrated, equitable, and focused data-driven health service delivery in order to improve the care that is given not only to the mothers, but to the newborns, the infants, and children as well.
Yeah, no, absolutely agree, Dr. Mendeville, and thank you for that, because you mentioned that you have mentioned several times information, data, not only to demonstrate that you have eliminated a disease, to make decisions on daily basis based on evidence that you have, and the partnership with the private sector. I really appreciate that you have highlighted that several times during your presentation and now in this discussion, because that is the reality. This is an effort of the entire sector, not private, public, and also how you identify that surveillance is key. And that is not only for HIV, syphilis, and hepatitis B, is the opportunity to provide integrated health services to really move forward to improving health of those that are affected for multiple diseases and events. So thank you very much for sharing that. And now I'm going to switch into Spanish.
Dr. Chu, like I have asked the other colleagues from El Salvador and Barbados, what would you recommend in practical terms to countries who would like to guarantee comprehensive care of a prison population? You've spent over 18 years working in the prison population healthcare. So what would you recommend to other countries who would like to accelerate this approach in the prison population? Okay, it's difficult. I mean, I will not lie to you. 18 years and we're still struggling. Our brothers and sisters from other countries in this session, what could I say? I mean, sit around in a technical group with all the stakeholders, not only sitting around the table, but we all know this, the Ministry of Health will always do its fair share. But the other stakeholders, the Ministry of Government, those who build the jails, who manage the jails, they have to do their fair share, as well as the Ministry of Security in each country. So as physicians, as the Ministry of Health, I mean, guidelines for tuberculosis with HIV, I mean, robust guidelines. You put that as part of the prison system, and of course, nobody can argue against you, and that's how we treat this prison population in a timely basis. But let me put it in this way: trying to decrease the incidence of tuberculosis and HIV in the prison system. The problem will never be the lack of care, the lack of medicines or drugs. It's just overcrowding. If we have overcrowding, we're not moving forward. So this is something we have to work as a team together with the Ministry of Government and the Ministry of Security. So my recommendation, basic recommendation, is to sit discuss trying to figure out and solve the overcrowding and to have isolation areas for these inmates. And I believe that my summary is that trying to decrease the overcrowding and control of inmates with tuberculosis and HIV. Okay, this is the end of this fruitful session. I'd like to thank our speakers today, Dr. Portillo from the Ministry of Health from El Salvador, Dr. Chu from Ministry of Health in Panama, Dr. Elizabeth Mandeville from the Ministry of Health and Wellness in Barbados. Thank you so very much for sharing your experiences with us. Those in the sessions, thank you for joining, listening to these lessons learned. We will be sharing in the webpage the recordings in all 4 languages so that you can listen to those experiences so you can have them. To the interpreters and PAHO colleagues, thank you, everyone, and have a great day. Thank you and goodbye.